Hi, this is Dr. Surapaneni. The topic for today is cellulitis. Some definitions to keep in mind when referring to cellulitis includes a superficial form of cellulitis called Erysipelas, which refers to infection of the epidermis, upper layers of the dermis, and involvement of lymphatics, while cellulitis refers to the deeper layers of dermis and subcutaneous tissue. Although clinically it's irrelevant and often difficult to differentiate erysipelas from cellulitis, but there's some key findings to look for. Erysipelas tends to be more localized to the face or the lower legs, and cellulitis tends to show up in the lower extremities. The border of erysipelas can be more defined as opposed to irregular borders associated with cellulitis. On the left-hand side, you see cellulitis of the lower extremity. On the right-hand side is a close illustration of what erysipelas could look like. Usually you see a butterfly pattern, intense redness, orange peel appearance, and incredible swelling compared to cellulitis. Some commonly implicated bacteria include group A strep, Staph aureus, or methicillin-resistant Staph aureus, Haemophilus influenza, Yersinia. Cellulitis is predominantly caused by group A strep and Staph aureus. Physicians often look for relevant history along with the infection on their exam to empirically cover potential pathogens. For example, a patient who's a diabetic with a foot wound or a puncture wound should also be covered for Pseudomonas. A child with cellulitis should be covered for Haemophilus. In patients with animal bites like dogs and cats, think Pasteurella multisida. Some cardinal symptoms associated with cellulitis include redness, tenderness, swelling, warmth, and induration. The mechanism behind skin infections like cellulitis and erysipelas is easier to understand if you just recognize that any opening in your skin, like wounds, scrapes, can lead to an entry for bacteria, which basically will then infect the epidermis, dermis, and the subcutaneous tissues, resulting in infections like cellulitis. Some common predisposing skin conditions that result in cellulitis include open scrapes, skin injury from trauma, eczema, skin infections due to surgeries, skin rashes like tinea infections, insect or bug bites, obesity, having skin conditions like lymphedema or venous insufficiency, immunocompromised state, having pressure sores, or being bedridden. Some dreaded complications of cellulitis can be spread of the infection to the bloodstream, causing bacteremia and eventually systemic infection called sepsis. Also can result in local abscess. If it's erysipelas, it has been associated with spread of the infection to the central nervous system, causing meningitis. One complication I want to mention is necrotizing fasciitis, when the top layer of the muscles called the fascia is affected due to penetration of bacteria through the skin once an infection like cellulitis is set in. This is more commonly observed in patients who have undergone surgeries, and post-surgery, the surgical site or incision site could be a source of infection. Some telltale symptoms of necrotizing fasciitis include skin edema, necrosis, which is dark, purplish color, indicating skin death, wound edema around the wound, and pain associated with the wound. Necrotizing fasciitis will be associated with systemic findings like fevers, low blood pressures, confusion, which could be indicative of sepsis, and laboratory findings remarkable for elevated white blood cell count and cultures, like blood cultures, that are positive for bacteria. Some initial approaches to treatments include empiric use of antibiotics, like with amoxicillin, clindamycin, etc. Remembering to raise the limb that's affected to decrease swelling, using compression stockings, using ice packs. If not responding to oral antibiotics, treatment should be switched to IV antibiotics. When treating infections associated with Staph aureus, it's important to choose antibiotics that are more likely to kill this bacteria, like Bactrim, vancomycin. Although initial testing is not always performed, but culture data from wounds and blood cultures can direct us in terms of the appropriate use of antibiotics based on sensitivities. More specifically, coverage for methicillin-resistant Staph aureus or MRSA involves oral antibiotics like doxycycline, Bactrim, Zyvox, clindamycin, and IV antibiotics like IV clindamycin, IV Bactrim, IV vancomycin, IV Zyvox. In summary, early recognition of cellulitis or erysipelas and local treatment of this infection with empiric antibiotics can prevent progression of the infection to complications like abscess, necrotizing fasciitis, or systemic illness like sepsis syndrome.